The next topic is the male genital tract. The male genital tract is composed of the penis, the testis and the epididymis, and the prostate. Let's take up the penis first. The penis can be affected by congenital anomalies, inflammations, and tumors. Inflammations and tumors being the most important. There are congenital anomalies, namely hypospadias, epispadias, and phimosis. Your hypospadia and epispadia are malformation of the urethral groove and urethral canal, and it creates an abnormal urethral opening, either on the ventral surface of the penis, that is your hypospadia, and in the dorsal surface, that is your epispadia. Hypospadia, the more common of the two, occurs in approximately 1 in 300 live male births. Even when isolated, these urethral defects may have clinical significance because the abnormal opening is often constricted, resulting in urinary tract obstruction and increased risk of ascending urinary tract infections. The next is phimosis. When the orifice of the prepuce is too small to permit its normal retraction, the condition is designated as phimosis. The next is inflammation. Inflammation of the penis include specific infections secondary to syphilis, gonorrhea, chancroid, granuloma inguinale, and genital herpes. Balanopostesis is an infection of the glands and prepuce, which is secondary to your Candida albicans, anaerobic bacteria, Gardnerella, and pyogenic granuloma. The penis is not spared from tumors. You have benign tumors and malignant tumors that affect your penis. Benign tumors are secondary to human papillomavirus 6 and 11, exemplified by your condyloma acuminatum or your genital wart. A wart is termed condyloma or condyloma acuminatum if it is located in the anogenital area. It may be single or multiple, sessile or pedunculated, red papillary excrescences. Under the microscope, you can see acanthosis or hyperplasia of the lining stratified squamous epithelium and coilocytosis. So here is a picture of your condyloma acuminatum. This is histologic picture wherein you can see papillary excrescences and your lining stratified squamous epithelium is hyperplastic or increased in the thickness of your lining epithelium. The other slide will show us the coilocytosis, wherein the cells are enlarged and they have vacuolated cytoplasm, and the nucleus is eccentrically located and pycnotic. So coilocyte or coilocytosis is a hallmark of your HPV infection or your condyloma acuminatum. Malignant tumors can be in situ or invasive. Your carcinoma in situ, which is termed your Bowen disease, is a solitary which occurs in patients older than 35 years of age, and this kind of carcinoma in situ may progress to an invasive squamous cell carcinoma. Another carcinoma in situ that involves your penis is your Bowenoid papillosis. If your Bowen disease is solitary, your Bowenoid papillosis is multiple, and they occur in younger age group. But this kind of carcinoma in situ does not develop into an invasive carcinoma. So here is a histologic picture of your carcinoma in situ. As what I have said in the previous lecture in the breast, no, about the basement membrane, here is a good example of your carcinoma in situ or the presence of your basement membrane. So here is a picture of a lining stratified squamous epithelium which is hyperplastic, and all layers are replaced by your neoplastic cells. But the neoplastic cells are within, no, the lining epithelium. It does not invade the stroma yet, no, as you can see in the other slide, no, the higher magnification, wherein the basement membrane is still intact. It does not invade into the surrounding stroma yet. That's why you call it the carcinoma in situ. If you have carcinoma in situ, of course, you have an invasive carcinoma. If your condyloma acuminatum is caused by your HPV 6 and 11, your invasive squamous cell carcinoma is caused by your HPV 16 and 18. So your squamous cell carcinoma of the penis is associated with poor genital hygiene and with high-risk HPV infection. Carcinomas are usually found in patients between the ages of 40 and 70 years. You have also a verrucous carcinoma, which is an exophytic, well-differentiated variant of squamous cell carcinoma that are locally invasive, but they rarely metastasize. So your verrucous carcinoma is also a squamous cell carcinoma, but a well-differentiated type. So here is a picture of your invasive squamous cell carcinoma, wherein nests of tumor cells are seen infiltrating your underlying stroma. One of the pathognomonic features histologically of your squamous cell carcinoma is the presence of your keratin pearl formation. The pinkish material, no, at the center of the slide is your keratin pearl formation. So this is the microscopic picture of your invasive squamous cell carcinoma. Let's go to testis and epididymis. Let's go to testis and epididymis. Cryptorchidism and testicular atrophy, or undescended testicle, is a complete or partial failure of the intra-abdominal testis to descend into the scrotal sac and is associated with testicular dysfunction and an increased risk of testicular cancer. It cannot be certain in the first year of life. It represents a complete or incomplete failure of the intra-abdominal testis to descend into the scrotal sac. If the testis remains outside the scrotum, it atrophies after 5 or 6 years. It is unilateral or one side only in most cases, but can be bilateral in 25% of cases. Histologic changes begin as early as 2 years. No? What are the histologic changes? You can have germ cell development arrest, marked hyalinization and thickening of your basement membrane, and Leydig cell hyperplasia. And of course, the testis is small in size. What are the complications? Complications include sterility if it is bilateral. and it increases the risk of testicular malignancy. Placement of the testis in the scrotal sac or your orchiopexy does not guarantee fertility, nor does it decrease the risk of testicular malignancy. The current recommendations are for correction at 6 to 12 months of age. Let's go to atrophy and decreased fertility. What are the causes? You have progressive atherosclerotic narrowing of the blood supply in old age, end stage of an inflammatory orchitis, cryptorchidism, hypopituitarism, generalized malnutrition or cachexia, irradiation, prolonged administration of anti-androgen, which is used in the treatment of prostatic carcinoma, and exhaustion atrophy. Let's go to inflammatory lesions. Epididymis is much more affected than the testis proper. Let's take up the mumps orchitis. They are rare in children, but it occurs in 15 to 20% of adults with mumps. It is characterized by an enlarged testicle, edema, and chronic inflammation. It may lead to testicular atrophy and scarring. If bilateral, it can cause infertility. Nonspecific epididymitis and orchitis may be secondary to bacterial infection and is a form of ascending infection, and the infiltrates are of the neutrophilic type. You have also granulomatous orchitis, and suspected cause would be an autoimmune process. It is present in middle-aged persons as a moderately tender testicular mass of sudden onset, sometimes associated with fever. It may appear insidiously, however, as a painless testicular mass. It may mimic a testicular tumor. That's why it's very important to work up these patients. Under the microscope, you can see granulomas just like the granulomatous inflammation seen in other areas of the body, wherein you can have epithelioid histiocytes and some multinucleated Langhans giant cells. Specific inflammations caused by gonorrhea, mumps, tuberculosis, and syphilis can also be seen. So let's go now to testicular neoplasms or testicular tumors. The most important cause of painless testicular enlargement is a testicular tumor. So if the patient will present as a painless testicular enlargement, think of a testicular tumor. The peak incidence is 15 to 34 years of age, and virtually, take note, virtually all testicular neoplasms are malignant. Cryptorchidism increases the risk 10 to 40-fold. Testicular dysgenesis, such as your Klinefelter syndrome, and testicular feminization increases the risk. Siblings of patients with testicular cancer are also at increased risk. And Caucasians are more affected than African Americans. There are two categories of testicular neoplasm. You have the germ cell and the non-germinal. Most testicular germ cell tumors originate from a precursor lesion called the intratubular germ cell neoplasia. So 95% of them arise from the germ cell. And only 5% arise from the support cells like your Leydig cell or your Sertoli cells. They are also divided into tumors with one histologic pattern and tumors with more than one histologic pattern. Testicular neoplasms that has one histologic pattern are the following. You have seminoma, embryonal carcinoma, yolk sac tumor, choriocarcinoma, teratomas, whether they are mature, immature, or with malignant transformation. Testicular neoplasms with more than one histologic pattern are embryonal carcinoma plus teratoma, choriocarcinoma and other types, and other combinations. So your germ cell, you have an embryo and embryo-related cells which will make up your yolk sac tumor, your teratoma, your choriocarcinoma, your embryonal cell carcinoma. On the other hand, your mature testicular cell type will cause your seminoma. So let's take up seminoma first, which is the most common type of germ cell tumor and comprises 50% of all the tumors. So the peak incidence is in the third decade of life, and they never occur in infants. It contains isochromosome 12p and express OCT3/4 and NANOG. And 25% have KIT activating mutations. So seminoma has a counterpart in the ovary, and you call it in the ovary as dysgerminoma. In other areas of the body, you can also see this, and you call that only germinoma. So these seminoma are large, soft, well-demarcated gray-white lesions that bulge from the cut surface. So that is the gross appearance of the testis with a seminoma. More than half of cases, the testis is entirely replaced by the tumor. So when you do a cut section of the testis that is affected by the tumor, almost all are covered by the neoplastic cell or by the tumor. You cannot see normal testicular tissue anymore. Usually, there is no hemorrhage and there is also no necrosis. Under the microscope, you can see large cells with clear cytoplasm, and they form nests, and they are separated by a fibrous septae. And these fibrous septae are infiltrated by your lymphocytes. So if you see nests of large cells with clear cytoplasm segregated into nodular pattern by a fibrous septae, which is infiltrated by lymphocytes, that is your seminoma. So, in the exam, if I will tell you, this particular testicular tumor shows nests of large clear cytoplasm surrounded by fibrous stroma or fibrous septae infiltrated by lymphocytes, the answer would be seminoma. So these tumors are negative for alpha-fetoprotein or your human chorionic gonadotropin. They are positive for PLAP or your placental alkaline phosphatase, your KIT, and your OCT4. Approximately 15% contains syncytial giant cells and HCG. That's why your serum HCG may also be elevated. So this is the gross picture of your seminoma or testis affected by seminoma. The lighter color would be your tumor and the darker color would be your normal testicle. The other side will show us the microscopic picture of seminoma wherein you have large cells, pale nuclei, and you have lymphocytic infiltrates. The dark ones with an arrow, pointed by an arrow, are your lymphocytes. The next tumor would be embryonal carcinoma. Usually, embryonal carcinoma are smaller in size and it does not replace the entire testis. It is ill-defined, invasive masses with hemorrhage and necrosis. Your seminoma has no hemorrhage and necrosis. This type of tumor metastasizes early. It is composed of large sheets of cells with glandular, it forms glands, and papillary formation. No? So you have glands, you have papillae in your embryonal carcinoma. The neoplastic cells are large. They are angry-looking, hyperchromatic nuclei, and they have prominent nucleoli. Mitotic figures and tumor giant cells are many or numerous or frequent. So you can see a lot of mitotic figures and tumor giant cells in your embryonal carcinoma. And the tumor cells are large, angry-looking, hyperchromatic, no, prominent nucleoli. No, they form glands, they form papillae. That is your embryonal carcinoma. Your embryonal carcinoma may be positive for OCT3 or 4 and PLAP, no? Placental alkaline phosphatase. They may be also positive for cytokeratin and CD30, but they are negative for KIT. Pure embryonal carcinoma are only rare, no? Approximately 3% of the cases. Mixed tumors are 45%. Sometimes you cannot see pure, no, germ cell tumor, no, even a seminoma. Most of the time they are mixed. So you can sign it out as a mixed germ cell tumor. So here is a picture of your embryonal carcinoma. So the normal testis is at the periphery. At the center is your tumor. You can see that there is areas of hemorrhage and necrosis at the center. Unlike your seminoma that it has a gray tan color with no hemorrhage and necrosis. On the other side is your microscopic picture of your embryonal carcinoma. You can see glandular formation of tumor cells. Some are in sheets. No? So if you see glands, papillae, and sheets of hyperchromatic pleomorphic cells, that is your embryonal carcinoma. Let's go now to your yolk sac tumor. It is also known as an endodermal sinus tumor. The origin is extra-embryonic mesenchyme arising in totipotential germ cells. This is the most common primary testicular neoplasm in children less than 3 years of age, and it has a good prognosis. In children, these are almost all pure yolk sac tumors. In adults, almost all are mixed with embryonal carcinoma. Yolk sac tumor will show us a non-encapsulated and homogeneous yellow-white mucinous appearance on gross examination. And on microscopic examination, it will give us an endodermal sinus feature of the placenta. So, it forms sheaths and nests with microcysts, and the histologic feature of this tumor is the presence of your glomeruloid structures. It looks like a glomerulus of the kidney. You call them the Schiller-Duval bodies. Yolk sac tumors are positive for alpha fetoprotein and alpha 1 antitrypsin. The next tumor is choriocarcinoma. They are trophoblastic differentiation arising in totipotential germ cells. Often there are small, palpable masses even with metastasis. Sheets of small cuboidal cells intermingled with syncytial cells. We can see in choriocarcinoma presence of cytotrophoblasts and syncytiotrophoblasts. And immunocytochemistry will give us a positive HCG. So this is a microscopic picture of your choriocarcinoma wherein you can see syncytiotrophoblasts and cytotrophoblasts, no, which are commonly seen in placental tissues. Let's go now to teratoma. Teratoma are somatic cell differentiation arising in totipotential germ cells. Usually, they involve all three germ lines. You have skin with cartilage and gut. If you see more than one recognizable germ layer type, it is a teratoma. Teratomas are large, 5 to 10 centimeter in diameter, and gross appearance is heterogeneous. You can see a solid area, some cystic areas. You can see cartilaginous. At times, you can see teeth, sebum, hair. No, so it's cystic mass, no, that when you do cut section, you can see a solid area, a cystic area. You can see sebum, you can see hair, you can see cartilage, you can see teeth. When you see that, you think of teratoma. So they are composed of neural tissue, muscle bundles, islands of cartilage, cluster of squamous epithelium, thyroid gland, bronchial epithelium, intestinal wall, and brain tissue. So if you see more than one germ layer type of tumor, that is teratoma. There are two types, the benign and the malignant. The mature, which is the benign, you call it mature teratoma, that is benign. You see fully differentiated tissues. But when it is malignant, you see immature cells, no? So the fetal type of tissues. You can also have teratoma with malignant transformation. Develop frank malignancy in teratomatous elements. So what are these malignant transformation cells? So most of the time you can see squamous cell carcinoma or adenocarcinoma. You can also have a teratocarcinoma. It is a teratoma combined with embryonal carcinoma. Post-pubertal teratomas all have an associated germ cell neoplastic component. Unlike in the ovary, wherein you also have a teratoma, but most of the time in the ovary, the teratomas are benign. The opposite is true with the testis. Teratomas in adult testicle are all malignant. So in the ovary, they are most likely, most of the time benign, but in the testis, most of the time they are malignant. So here is a picture, no? You can see in the teratoma, glandular formation, you can see cartilage, you can see squamous cells. So as what I have said, no? In the ovary, almost all, no, of them are benign, but you can also see immature teratoma, no, with immature elements. So that is the malignant type of teratoma. You have also mixed germ cell tumors. It comprises 50 to 60% of all testicular neoplasms. The most common is the teratocarcinoma. It is a combination of your teratoma and embryonal carcinoma. So I would just like to reiterate again that all teratomas in the adult testicle are all malignant. So what are the clinical features of your testicular neoplasms? So they are painless enlargement of the testis. Some present as metastasis. Your seminoma will metastasize in the iliac and para-aortic lymph nodes. While your other types of tumors may metastasize in the lymph nodes, also in the liver and in the lung. So what are some of the tumor markers? For choriocarcinoma, you can request for beta-HCG. In yolk sac tumor, you can request for alpha-fetoprotein. They are helpful in the diagnosis and in follow-up of your patients. So how do you stage? Clinical staging of testicular CA. Stage 1, the tumor is confined to the testis in the epididymis or spermatic cord. Stage 2, there is already distant spread but confined to the retroperitoneal nodes below the diaphragm. And stage 3, metastasis outside the retroperitoneal nodes or above the diaphragm. Let's go to the tumors of sex cord or the gonadal stroma. You have Leydig cell tumor or interstitial cell tumor. It occurs to 20 to 60 years of age. Gynecomastia may be present and may elaborate some hormones. Your androblastoma or your Sertoli cell tumors. They may elaborate either your estrogen or androgen, and gynecomastia is also present. No, but these are rare, no, tumors of the testis. The most common is your seminoma. So what are the treatment options for patients with testicular neoplasm? So seminomas are radiosensitive, and you can also have a cisplatin-based chemotherapy for others. So let's go now to the prostate. So you have also inflammatory lesions, nodular hyperplasia, and adenocarcinoma of the prostate. So let's take up prostatitis first. Prostatitis could be acute and chronic. Acute bacterial prostatitis is caused by E. coli or other gram-negative rods. The same organism that causes your urinary tract infection causes your acute bacterial prostatitis. Chronic prostatitis. It may follow episodes of acute prostatitis. It may develop insidiously. Most of them are abacterial. Causes are your chlamydia trachomatis and ureaplasma urealyticum. In acute prostatitis, of course, no, just like in any other inflammation, the infiltrates are your polymorphonuclears or your neutrophils. In chronic prostatitis, you have a variable mononuclear infiltrates. Your lymphocytes, your plasma cells, your histiocytes are seen in your chronic prostatitis. You can also have granulomatous prostatitis, which is caused by your tuberculosis, fungi, and sarcoid. What are the clinical presentation of patients with prostatitis? They can have dysuria, difficulty in urination, urinary frequency, low back pain, pelvic pain, fever, and increased leukocyte count. These are your clinical features of your prostatitis. Normally, the prostate weighs 20 grams. It is located in the retroperitoneal area. It encircles the neck of the bladder and urethra, and it is devoid of a distinct capsule. It has 5 lobes: the posterior, the middle, the anterior, and 2 lateral lobes. It has 4 zones or regions, namely your peripheral, your central, transitional, and periurethral. Your hyperplasias, or benign prostatic hypertrophy, as what the clinicians would call it, are located in the transitional and periurethral zones, while your carcinomas occur in the peripheral zone. So here is an illustration, no? At the center, you have there the prostatic urethra. The gray is your central zone, and you have the peripheral zone, no? So here, you have the peripheral zone, the urethra at the center, and you have your central zone. So let's go to the nodular hyperplasia of the prostate, or forever has been referred to as the BPH, or the benign prostatic hypertrophy. But it is not hypertrophy. It is hyperplasia. If you remember your cell injury, hypertrophy is defined as what? Increase in the size of the cell, while your hyperplasia is increased in the number, no, of the cell. In return, it will also increase in size. So the better term is nodular hyperplasia, not benign prostatic hypertrophy, but nodular hyperplasia. So your nodular hyperplasia arises in the central zone. It involves glands and stroma, and it present in 15 to 20% of 40 years old males, and present in 85 to 90% of 70-year-old males. So, men, as you grow old, it is expected that your prostate will enlarge. No? So you can see it in 40 years of age, 15 to 20%, and if you are 70-year-old, so it occurs in or present in 85 to 90% of cases. So it requires androgen and estrogen, and it requires an intact testis, no, for you to have a nodular hyperplasia. So the prostate is enlarged. You have multiple nodules. There is urethral compression. And under the microscope, you can see proliferation of both your glandular elements and your stromal component. So here is a picture of your nodular hyperplasia of the prostate. So you have there nodules, several nodules. So another picture, no, of your nodular hyperplasia. Under the microscope, you can see proliferation of both your glands and your stroma. So there is proliferation of the glandular and the fibromuscular stroma. The glands there are lined by 2 layers of epithelial cells, unlike in your malignancy wherein you can only see single layer of cells. Of all patients with nodular hyperplasia, only 10 to 15% have symptoms. So most of the time, patients have no symptoms in cases of nodular hyperplasia. So the symptoms are of the lower urinary tract, partial obstruction, no? So hesitancy, small amount of urine, dysuria. Those are your symptoms. So what are partial obstruction? No? Difficulty initiating urine stream or hesitancy, interruption of stream, frequency, urgency, nocturia. No? So increased urine output. Urine output is increased at night. No? So if you do your rectal exam, you have a soft and boggy prostate. You can also have complete obstruction. In complete obstruction, you can have painful bladder distension, hydronephrosis, and anuria. So some of the complications, since you have increased in residual urine, your risk of urinary tract infection is also increased. But take note, your nodular hyperplasia does not increase the risk of developing prostatic carcinoma. So let's go now to carcinoma of the prostate. This is the most common visceral cancer in males and the second most cause of cancer-related death. Lung cancer is still most common in males. This occurs in older men over 65 years of age. You can also have latent cancer or no symptoms in as many as 50% of males more than 80 years of age. The cause is unknown, but genetic, hormonal, and environmental factors are important. Growth of carcinoma can be inhibited by orchiectomy or use of estrogen therapy. That's why one of the treatment of prostatic cancer is orchiectomy or they are given estrogen therapy. Symptomatic cancer is more common in African Americans than in Caucasians, Asians, or Hispanics. So most of the time, your prostate cancer arises in the peripheral zone. That's why they are palpable and they feel like a pebble if you do your rectal examination. So if you have prostate cancer, urinary obstruction is less likely to occur because your tumor arises in the peripheral zone, not in the central zone. So what will give you a urinary obstruction symptom? Your nodular hyperplasia, because your nodular hyperplasia arises from the central zone, not in the peripheral zone. Your prostatic carcinoma will not give you a urinary obstruction symptom because they are peripherally located. So your gross picture of your prostate cancer is ill-defined, non-nodular, no, unlike in contrast with your nodular hyperplasia, that it is nodular. Here it is non-nodular and it has a gray-white to yellow in color. So basta yellowish, no? If you see yellowish scrapings from the transurethral resection of the prostate, you suspect that it is a prostatic carcinoma. Prostatic carcinoma can metastasize to regional lymph nodes. It can also invade your seminal vesicles. And also, it can infiltrate the urinary bladder and the rectum. What is the morphology of your prostate carcinoma? They are adenocarcinomas. They are arranged in back-to-back arrangement. They are lined by single layer of cells, unlike in your nodular hyperplasia, wherein the glands are lined by two layers of epithelial cells. Prostatic carcinoma are graded histologically, and the histologic grading is helpful in predicting prognosis of the patient. The higher the histologic grade, of course, the worse is the prognosis compared to a patient where the histologic grade is low. So here is a picture of your prostatic adenocarcinoma. The glands here are in back-to-back arrangement, and they are lined by single layer of cells. Most of the time, the prostate carcinoma are silent. They are peripheral, not central, so they do not cause obstruction. 15 to 20% as are discovered in TURPs or in your transurethral resection of the prostate. But your TURP are done for nodular hyperplasia, not for cancer. Because as I've said, cancer arises from the peripheral zone, while your nodular hyperplasia arises from the central zone. So if you do TURP, you scrape the central portion. So TURPs are done for nodular hyperplasia. But if you want to work up your patient and if you are suspecting for a prostatic carcinoma, you do needle biopsy, transrectal needle biopsy. So prostate carcinoma are seen in autopsy of men older than 80 years old. So 50 to 60% have occult prostate cancer. So a digital rectal exam is critically important. So prostate cancer may present primarily with metastasis. Bone mets are frequently osteoblastic and present in the eggshell skeleton. They are osteoblastic, not lytic, metastasis in a male patient, and they are virtually diagnostic of prostatic cancer. So if you see an osteoblastic lesion in a male patient, you think of a metastatic prostatic carcinoma. So you screen your patients or males 50 years old and above. You screen with PSA or your prostate-specific antigen. But your prostate-specific antigen is specific only to the prostate. It can be produced by both normal and neoplastic cells. PSA is not only elevated in adenocarcinoma of the prostate. It can be elevated in cases of prostatitis or inflammation of the prostate or in benign lesions such as your nodular hyperplasia. So you can screen patients with PSA. Elevated values take on much more significance when combined with your rectal examination, transrectal sonography, and by needle biopsy. The normal value for your PSA is 4 nanogram per ml. If your patient presents with obstruction and has a PSA of 10, you do a needle biopsy to know whether that patient has only a benign lesion or a malignant lesion. So serial follow-up of PSA in patients with prostate cancer is useful to monitor the disease for recurrence or progression. If you have a cancer patient that has been treated for prostatic CA and then you do your PSA, and if your PSA is still increasing, meaning your patient is not responding to your treatment. But if your PSA is decreasing or went to a very, very low level like 1 or 0, so meaning your patient is responding to the treatment that you gave to your patient. So anatomic staging along with histologic grading is very important for prognosis. So histologic grading of prostate cancer is by the Gleason system. The Gleason system uses the 5 grades on the basis of the glandular pattern of differentiation. Grade 1 being the most differentiated tumors, meaning it looks like very similar to the normal prostatic glands. And your grade 5 shows no glandular differentiation. It You can see cords, sheets, and nest of tumor cells. So grades 1, 2, 3, 4, and 5. Grade 1, well differentiated, to grade 5, the poorly differentiated tumor. So how do you score Gleason? So you have two numeric grades. They are added to obtain a combined Gleason score. So you scan the slide. The primary grade is assigned to the dominant pattern and a secondary grade to the second most frequent pattern. Like if you look at the slides, and most of the patterns are grade 4. The secondary dominant pattern is 3. So your Gleason score is 7. Put in the parenthesis 4, which is the primary grade, the dominant pattern, and 3, the second dominant grade. So Gleason score 7, meaning 4 plus 3. But if your Gleason score is 7, but it is 3 plus 4, meaning the dominant is grade 3, and the secondary dominant is 4. So grade 7 can be 4 plus 3 or 3 plus 7. The list, the latest recommendation, the least grade that you can give to adenocarcinoma of the prostate is 3. There is no more 1 and 2, but the list is 3 in cribriform pattern. You don't have to memorize, or I can give this to you on March 27, when we will have discussion on the microscopic features of the different tumors. So 80 to 90% has a 10-year survival in patients with limited disease, but only 10 to 15% 10-year survival in patients with disseminated disease. So we have a term, prostate intraepithelial neoplasia. So it is a preferred term for a process involving ducts and acini, also described as ductal acinar dysplasia. It can be a low-grade and a high-grade PIN, but only high-grade PIN is diagnosed and reported. We don't report low-grade PIN in histopathology reports. We only report the high-grade. So what are these PIN? They are single or multiple foci of glands with intra-acinar proliferation of cells that demonstrate nuclear anaplasia. There is no invasion. The dysplastic cells are surrounded by a layer of basal cells and an intact basement membrane. So here, again, the basement membrane is very important because there is no invasion in the stroma yet. So the prostate intraepithelial neoplasia. So it's still within the dilated gland. So many molecular changes are also seen in invasive cancer, and they're also present in PIN. So this is an intermediate lesion between the normal and frankly malignant tissue or malignant neoplasm of the prostate. So I think this ends my presentation in the male genital tract. On Tuesday next week, that is March 23, I will give you several case studies and also some seat work for you to do. You utilize your time on March 23 to do this. By groups, I will ask you to do a case presentation. I will give you cases, no? Breast cases, actual cases, no? Where we signed out in the hospital where I am affiliated with. So we will discuss actual cases in the breast, no? From the core needle biopsies to the lumpectomy to the sentinel node, no? To the ERPR HER2 status of the patient. We will discuss it. So on March 23, you utilize your time to do the presentation and answer the laboratory work. And on March 27, I will meet you face to face via Zoom. So I'll see you on March 27. Thank you for listening.